So welcome to this afternoon's Muscles Matter 2021 online seminar on respiratory care. I'm Rob Burley and I'm Director of Care, Communications and Support at Muscular Dystrophy UK, and it's my pleasure to be chairing this afternoon's conversation. So building on the success of our 2020 series, the MDUK Muscles Matter seminars have become a regular feature in MDUK's calendar, and we're hopeful that in the long term they don't completely replace our physical get-togethers, but we'll certainly continue to run alongside them as and when we start to be able to do events again. We're running 2 or 3 seminars a month, although this is actually the last one of 2021, and they focus on a range of general and condition-specific topics, and they include sessions on research, on practical and financial support, and on managing conditions. I think it's really key to highlight that our helpline remains available to anyone affected by a muscle wasting condition, and do please contact us if you have any questions or are in need of support. We can help you with information and can either support you directly or point you to where you need to get support from. The number and email address should be on the screen now, but you can call us on 0800 652 6352 or email us at info@musculardystrophyuk.org. We're really grateful to be joined by an expert panel covering a broad range of expertise and lived experience of respiratory care this afternoon. And we're also very grateful for the support of our sponsors, PTC Therapeutics and Roche. Before we begin, a note on how you can ask questions or make comments throughout the session. We've had some questions in advance and we'll seek to cover these later, but we'd also like to incorporate some live input. And to do that, we'll be using the Q&A function. So please type your question or comment and we will feed them into the discussion. To help us manage the technical side of the event, we won't be calling on questioners to ask their question directly, and any questions we don't manage to get to or that we don't know the answer to immediately, we'll seek to cover through the website or to get back in touch with you individually afterwards. And finally, a reminder that we're recording this session and it will be made available on the website over the next few days. So it's now my pleasure to introduce our panel. I'll introduce all our speakers and then I'll hand over to our first speaker to start this afternoon's session. So we're joined by Dr. Scott Davidson, who is the Deputy Medical Director of Acute Services at NHS Greater Glasgow and Clyde, and is also a consultant respiratory physician at the Queen Elizabeth University Hospital. Dr. Davidson qualified from the University of Aberdeen before completing his training in Glasgow and taking up a consultant post in 2006. Over the past 10 years, one of his clinical subspecialty interests has been the home ventilation of patients with neuromuscular diseases such as MND and Duchenne muscular dystrophy, leading the service until 2020. Alison Clark is the lead clinical nurse specialist for the long-term ventilation service covering the west of Scotland. She is also based at Queen Elizabeth University Hospital in Glasgow. She qualified in 1989 and has a wealth of experience working in the NHS, ranging from spinal injuries to respiratory medicine. In 2006, she began her role as clinical nurse specialist for ventilation, and in 2008 became the lead nurse for the service, developing an interest in neuromuscular patients within this role. Jodie Murphy is mum to 2 boys, Fraser 7 and Robbie 5. Fraser was born with congenital Nemaline myopathy, and Mahesh Malhotra is 38 years old and lives with Duchenne muscular dystrophy. So welcome to you all. So Dr. Davidson, if I could come to you first, please. I think you have some slides to help provide us with an overview of neuromuscular conditions from a respiratory perspective and the role of the home ventilation team. And you're on mute, I'm afraid.
With the amount of time I spend in meetings, you'd think I would know where the mute button is. Apologies and thanks for the invitation to speak today. I guess, as you said, Rob, I was previous lead and the pandemic kind of got in the way of that, and much of my time has been in coordinating things in GGC, and Alison obviously is lead nurse. I think it would be suffice to also describe Alison as the boss of the whole service. Alison's got just an absolute wealth of experience, and we often look to Alison as well for much advice. So in terms of home ventilation, and as you touched on, our expertise has been around patients with neuromuscular conditions, and it can be quite a daunting thing to come and meet an adult lung specialist, because the feeling is that if you're seeing a lung doctor, there's an issue with your breathing, and that can cause an awful lot of anxiety and strain. And so we've tried to develop a service where we meet folks from any stage through their journey and really build up a relationship with folks so that nothing ever should come as a surprise, nothing should come out of the blue. And so we have a really good relationship with our clients, and obviously we can have a good laugh and a joke at clinics and over the video, as we're doing an awful lot now, but we can obviously be incredibly serious and do what we need to do when we need to do it. So there's just a bit of a balance, and I do feel, and I think the whole team feel incredibly privileged to be working in this field. And as I say, I'm happy to take any questions today, and also as a follow-up as well. I'll just move on my slides, which don't want to move. So within our long-term ventilation service, we are based at the Queen Elizabeth University Hospital, but we look after patients across the board, certainly. There are 3 consultants that are involved in the service, and we have 4 whole-time equivalent ventilation nurse specialists. We do have a healthcare support worker, and we also have a physiotherapist who shows and has a real specialist interest within our neuromuscular population as well. So we would look after patients with any type of neuromuscular condition, some of which we get involved in earlier years, others we get involved in later, and some people we never have to get involved in, but we would often see and monitor them through the clinic. We will look after some people with chest wall deformities with no underlying neuromuscular condition, and we will look after some people, for example, whose their breathing muscles, for again any number of reasons, are just not functioning as well as we would like them to be. One of the things that people will often ask us is the role of respiratory monitoring. And I think for those folks that attend us or have been through the Royal Hospital for Children, everyone will talk about having sleep studies. And really that's what we are looking at. We're looking at a trace that looks something like this. And this is what we would call a TOSCA as compared to a sleep study. It's kind of a basic sleep study, but it gives you more information with regards what we are looking at, and that's an awful lot the carbon dioxide levels. And if you look at the top trace, that's your oxygen level, and the bottom trace is your carbon dioxide level. As you know, there's various stages of sleep, and often during the rapid eye movement, if there is an issue, that's when we start to see these dips in oxygen levels, and then they come back up, and then about 90 minutes later, they'll go back down. And then you'll start to see the carbon dioxide, as the oxygen level goes down, the carbon dioxide level just comes up a little bit. If I was to show you the pulse rate at the same time, you would tend to see the person's pulse rate just go up at the same time, just because that's a little bit of stress on the system. Often at this point, there's nothing we need to do, but it was just an example of what a TOSCA, that overnight tracing, when you come in, or as we would do the studies at home, that's what we are looking at. And we're looking at, a lot of what we look at is averages. So we're looking at the average carbon dioxide level over the course of a night, rather than simply spot one-off levels of carbon dioxide. But really importantly, we put that together with the symptoms and how folks are feeling. And that's incredibly important when you're putting all this together. So in terms of our monitoring, we do a 6-monthly transition clinic with the pediatric team. And again, that is primarily there for folks to get to know us, to be comfortable moving into the adult world, which can be, I think, quite daunting for folks. So that's something that we've built on over the last few years. And we will see folks anywhere from 3 to 4 to 6 to 12 monthly reviews. That will be based on patient preference. It will be based on how we know the sort of condition will evolve, and that allows the most appropriate use of time, both for individuals as well as us professionally. What we would never do is give someone a 12-month appointment if we anticipated something happening at, say, 6 months. We would always try. So people should have that confidence if we're suggesting a set period of time, that's absolutely fine. I think routinely and ahead of the pandemic, we would have measured a daytime transcutaneous CO2. So that's a carbon dioxide level that's measured through the skin just with an infrared probe type arrangement. For those folks who are a bit older, and certainly when I started this service off or took it over along with Alison in 2006, people may remember they used to have to get a needle either into their wrist to take a sample of blood from the artery, or we used to have to heat the ear up and then take a prick of blood from the earlobe to measure your transcutaneous or to measure your carbon dioxide level, whereas now we can just do it through the skin and it takes about 10 minutes. But really importantly, we base an awful lot of what we do on patient symptoms. So symptoms of underventilation, hypoventilation, and I think that is something that we become very accustomed to teasing out. Folks might not necessarily recognize it's happening because it tends to be a gradual evolution of symptoms, but we are looking at that situation of people beginning to feel tired during the day, waking up feeling cloudy-headed. People may describe it as having a hangover. People may just say, I have a bit of a headache when I get going, and then after I'm up, it tends to clear, and then maybe you start napping during the day a little bit. Sometimes it can be as subtle as you're just not concentrating as well. If you're at college, maybe your exam marks are just not quite as good. So there's all of these things that we build into our questions. We're looking to see if people are suffering from or experiencing lower respiratory tract infections. So if there's a number of chest infections, it might be that the breaths are just not going all the way down. So we're not clearing the phlegm just as effectively as we could do. And then also weight loss can be an indicator of that muscle weakening around the chest. So those symptoms are paramount. And then from the symptoms, we go on and check the overnight monitoring with the Tosca. And again, as I say, we're looking at averages there, and we're looking at averages of a carbon dioxide level of less than 6.5. A normal daytime carbon dioxide level is 6. And we put together that with the symptoms primarily. And we'll do lung functions when we need to, but so much of the folks that we look after, we base so much of what we do on the symptoms, and then the tracing from the overnight studies, as well as the spot daytime carbon dioxide, although we've done less of that, obviously, through the pandemic with not really getting folks into the hospital environment as we had done previously. But we've really taken to the virtual consultations, and then our nurse specialists and support workers going out as needed, and that's been a real benefit. And we've had some really, really good feedback around the ability to check in with people, have that eye-to-eye contact, but not have the stress of making your way up to the hospital, which can be quite an undertaking of a time. We would also look at the assessment of someone's cough. And when I say the assessment of someone's cough, it's often just, can I ask you to give me a cough? And then we can hear so much about the quality of a cough, and if that's going to be strong enough with regards to sort of clearing that phlegm or the sputum when it comes around, and then just the general health. I think over the years, we become, as I say, we're not the general practitioner for folks, but we get asked an awful lot about an awful lot of things, more than I would be asked in my sort of day-to-day respiratory side of things. And Alison and I have had some, again, it comes back to that privilege. It's a real privilege for folks to be involved in people wanting to come and ask us and share these sort of queries and concerns with us around things. So that's something else that we will do through the clinic, as well as the respiratory monitoring. But that's what we do as the sort of core of our function, along with the overnight studies. This is a fairly standard machine that we would use when we're looking at giving people that bit of breathing support overnight. People will be anxious about that, and that's absolutely understandable. Often when we start someone on the support overnight, the NIV, I think it would be fair to say that if we time it right and there are symptoms there, the machine will often, rather than be something an obstacle or an object of anxiety, it can become folks' best friends as well, because it really does help. And if you were to open up one of these machines, inside you'll find, in essence, a fan. That's all it is. It's not oxygen. It's nothing that puts extra oxygen into the lungs. It simply puts pressure in. And that's a fairly old machine now. There's now a NIPI 4 and NIPI 4 Plus that we would use, and there's various other machines, and some of them are really very small. And so those are the types of machines that we would look, and we are looking at those for people who have symptoms of the tiredness and such like during the day, and then that carbon dioxide level is either up whilst awake or above 6.5 on average overnight, after full discussion. And I think the other thing to remember, it's entirely an individual's choice if they want to have one of these or not, and not everyone needs them and not everyone wants them. That's a fairly standard mask that we would use. We have, if there's a mask available, we can pretty much get it, and we will use that. That's a mask that will go over the nose and the mouth. That's particularly effective overnight when people might tend to mouth breathe, for example, if you're just using a mask that went over the nose. But during the day, we'll have masks that people can wear if they do need it during the day, over the nose, which can still allow speech to a bit easier, and also can help with glasses and such like these. That one there can be a bit difficult to get your glasses to sit on the bridge of your nose. So there's various types of masks that we can look at. And again, that will be dependent on whether someone is wearing the support overnight or whether or not need it a bit more during the day. And in fact, you can wear a different mask at night and a different mask during the day. And we also have other types of masks now, or devices where it's just like a mouthpiece, and you can just literally put the mouthpiece in and use that. And that can sometimes be effective around meal times if people are getting breathless or tired after or before a meal. And so those are the types of breathing support and devices that we use. And everyone has a slightly different setting and a requirement in terms of pressures. But as I say, it's simply a pressure that goes into the lungs and opens the lungs up. So I would often describe people's lungs doing that. And then when we get started, they'll do that. And that is the expertise that we have. We make you go from that to that. So it sounds straightforward, but people will describe it, and I think it helps for folks. People will describe, oh, you're on a CPAP machine or you're on a BiPAP machine. Now, CPAP we very seldom use. CPAP is a bit like if you turn a fan on and it's just on, then you're breathing against that fan. No matter how you breathe, the fan is going at the same speed the whole time. So a bit like turning your hairdryer on at 2 and putting that in your mouth, that's what CPAP is effectively doing. That's still blowing the whole time. Whereas the machines that we would tend to use, were called bi-level ventilators. We tend not to use BiPAP because BiPAP is a company trademark name. So just in the spirit of fairness, we would tend to describe things as bi-level. So in essence, you'll hear us talking about IPAPs and EPAPs and pressure support. So as you breathe in, the fan will finish that breath. And then as you breathe out, the machine will almost turn off and just allow the elastic. Your lungs are like a big elastic ball. It just allows them to come back down and get rid of the carbon dioxide. It's the shallow breathing that allows the carbon dioxide to build up that gives you those symptoms. So we put the air in and then let the air come out naturally. We give a little bit of pressure as you're breathing out against it, and that's just to keep the bottom of the lungs open ever so slightly. I always describe that as if you take a new balloon out of the packet and the first breath into a balloon's quite hard and the second breath's much easier. So at the end of a breath out, if we just stop your lungs going all the way down, it's like taking that second puff into a balloon. So it's much easier to start the breath. So what we're doing is just taking away the work of breathing. And so breathing is much more easy, but individuals control the machine doesn't control you, if that makes sense. So again, if you go onto one of these machines and take 12 breaths, the machine will take exactly the same 12 breaths as you, but just finish the breath. If you then change and say, I'm going to take 16 breaths, the machine will just take the 16 breaths that you're doing as well. And every time new devices come out, the software inside them gets so much better, so it's so much more comfortable and in tune with folks breathing. So that's the type of machine that we use rather than CPAP alone. And it's sometimes helpful just to go through that and let people know. I think the other thing that people ask us and people are interested in, understandably, is that airway clearance, and that comes down to the strength of cough. And this is where Alison, so I guess the Alison and the physios have that expertise in terms of airway clearance. This is some folks on the call maybe have one of these, some folks on the call maybe don't know where they are. That's usually one of our questions. Do you have an ambu bag? Yes. Do you know where it is? Well, the last time I saw it, it was under the bed somewhere. And again, you can see it's simply a bag with a mask. And again, as you're taking a breath in, you squeeze on the bag, and all you're doing is pumping the lungs up a little bit so that you can then get a good cough. The work of breathing is breathing in. Breathing out is a passive thing because your muscles and your lungs just ping back the way. So it's the more you open them up, the more they'll come back down. So with a cough, it's about getting them aerated as much as we can. So the core component of that comes down to devices like an ambu bag. Nothing fancy, nothing sophisticated, but a real good thing to have and to be able to use. We do, however, go on to be able to use things such as called a cough assist device. And we put up two examples there of the devices that we have, one made by Philips and one made by BD. And in that, again, it's a mask that you would wear. But what that does is put an absolute pressure in, and then it will very rapidly cycle to a substantial negative pressure. So you're basically a lot of air in quickly, and then you go to a negative pressure and you're literally sucking stuff out. That is something that can be really important and really necessary. And if you're if you ever are unfortunate enough to be in hospital, a lot of what we will do will be the machine plus this sort of cough assist, but it can also be quite tiring because it is a real amount of pressure in and then that negative pressure out. So it can be quite a tiring undertaking, but it can really open up the lungs. And just other things that we can do, there are things called oscillating vests. So it's like that old-fashioned physio where you just shake the chest and you keep the phlegm moving around. So that's one thing. We don't tend to use that particularly. We tend to use more the ambu bag cough assist if we need to. And on occasion, if someone's particularly unwell or there's a bit of really sticky mucus that's maybe plugged somewhere, we can ultimately pop a very fine camera down, which is thinner than a pen, down through the nose, and then we can just suck that up and take it out. So that is a very straightforward technique as well. But again, we very seldom have to do that, but it's something that we can do. And in terms of, if you just look at a sort of general type scenario, you can maybe see that there's a black sort of triangle here as a lung, and then on this side it's much whiter. If I then show you you've got this black area here, and then you've not got the same black area here. So that left lung is just not opening up. And so if we do that cough assist regularly, and then the breathing support as well, we can get it to looking back like that, where we can open up that lung again, and then everything becomes so much easier. So those are just examples that I've drawn. So I'll stop my screen. I will try and stop sharing my screen. And that's really a whistle-stop tour of what we do, Rob, in terms of that monitoring through to support if we need to. And I'm happy to take any questions or go through the remainder of the session with you.
Thank you so much. That was fantastically clear, really helpful. I did catch Jodie smiling at the lost ambu bag, so we might come to that later in her remarks. But something that struck me, but I'll sort of pose this as a question more because I think it might come up in Alison's comments, but we might come back to it. But you spoke about people raising things with you beyond respiratory issues, and we've heard throughout the Muscle Matters series about the value of the multidisciplinary team. So it'd be interesting to hear as the session progresses about how you interlink back with other sort of specialists who would look after other areas of people's muscle wasted conditions. But Alison, you may cover that anyway as part of your remarks. So I'll come to you next, Alison. That's right. We'd love to hear a bit about your work and the work of the lead nurse. Yeah, Dr. Davidson did describe you as the boss, so I'm looking forward to hearing a bit more about that. So yeah, over to you, Alison.
Okay, hi, how are you? Thanks, Rob. So I'm Alison Clark, the lead ventilation nurse specialist for the team, as you've already heard. Just a wee bit about my role. Obviously, Scott went through that in good detail and it was nice and clear, and that's sort of what we do. But as the nurse specialist in a team like this, our role is quite varied. We do quite a lot of stuff. A lot of it is, a big part of it is on the phone actually, and communicating with the patients that way, email, stuff like that. But we tend to talk to patients a lot and see them. We see them in the community. Although our job is quite hospital based and our aim is to get our patients onto ventilation, once we get them on, and sometimes before we get them on, there's a lot of communicating just between us on the phone, or we'll go and visit them at home and things like that as well. So probably a bulk of it is a mix, although our aim is to get them in, get them onto ventilation and get them settled and comfortable and on the right thing that suits them and stuff like that. So we have mostly in-house stuff. We initiate people onto ventilation a couple of different ways. So generally bring them into the ward for a couple of nights, or we'll do them as day cases. It just depends on the person and what they would rather do a lot of the time. Do you know, we are quite individual patient focused, so it will depend really on them. Because we do quite intensive monitoring, we would rather bring them into the hospital, although we're dipping into the community a wee bit more doing these things. But it just becomes a wee bit more difficult just with other things. And COVID and stuff like that sort of stopped us doing a lot of stuff as well, like as in bringing patients in is a wee bit more difficult. It's a wee bit, because of the AGP and stuff like that, it's a wee bit harder for us to actually use specific rooms and stuff like that. So that's kind of gave us a wee bit of challenge again, but we're getting through it and we're coping. And a lot of our job that people forget or don't see, I think, is the equipment. We have millions of equipment, you know, masks, tubing, ventilators, ambu bags, and we have got a physio who's really good and dips in and does a lot of the airway clearance now, but before that the nurse has done it. So we're all pretty much, you know, trained up in these things. So if the physio is not available, we're kind of there. We can always answer most questions or help them out, and we tend to be the ones that will fix equipment. So if the equipment breaks down, they'll come through us. They don't tend to come through the physio, so they'll always come through the nursing staff. So we have got quite a tight, robust relationship, I suppose, with the patients and their families, and they get to know us all really well, and that's probably the way it works. I think it works better that way. We like to get to know everybody and for them to trust us and know that they can call on us at any time. But we do a lot of different things. We do clinics, we do nurse-led clinics, we do joint clinics with consultants, we'll do home visits, we'll bring them up to the hospital. We just do whatever's needed. We're quite flexible. Although we're a kind of Monday to Friday set, I know that sounds like we're quite flexible, but we are Monday to Friday. That's just the way the service is. However, we've got sort of for ventilation problems with your machines. We've got like an on-call system over the weekend. So if anybody's ventilators broke down over the weekend, they can get it replaced through the medical physics service. So we link in with, talking about MDTs, we link in with a lot of different people. So physiologists are a big part of the team. We link in with them, they download a lot of our equipment, the overnight sleep studies and stuff like that. And medical physics, who service our equipment, take it in and out of patients as well. So they've got a big role in that, just taking stuff out if things break, because we can't just, we cover sort of a wide area. So we cover, I never said that at the beginning, the west of Scotland and a wee bit beyond. So it can be quite difficult just to run out and see somebody just at the drop of a hat, although I think we probably do that quite well anyway, do you know what I mean? So we try our best. What else? So nurse-led clinics and stuff like that. So it's quite varied. It's interesting, really interesting. We get to meet a lot of amazing patients. We love it. We love all the patients. They seem to be happy with what we do. Do you know what I mean? We don't tend to rub anybody up the wrong way, I don't think. So any questions, just fire away. I probably could talk all day about my job, but there isn't any point. So just ask away and we'll try and answer them.
Fantastic. Thank you very much. I think a theme from both speakers so far has been the importance of the communication between the health professional and the patient, and almost a partnership that grows. So I'm going to put Jodie and Mahesh on notice that that's something I'd love to hear your perspective on. Before I come to Jodie first, though, we've had a question actually that's very relevant to something that Dr. Davidson sort of touched on that I think actually I'll come to now, which is just around whether there's just a geographic difference in the use of the vests that you pointed out, and because the question highlights that they're a primary go-to in the States for most people with respiratory needs. So yeah, just interesting, is that something you're aware of in terms of that international difference and geographic difference in the approach to those vests?
Yeah, I mean, I guess in terms of respiratory support and how we look after folks, there's a difference internationally in many things, Rob, in terms of, the types of ventilation we undertake, and that will differ. And there's some people who have very different views to others across the world. And in terms of the vest, I think we have found certainly the ambu bags and just the convenience of that, in terms of just popping a mask over and doing that just to be effective. I think the vest and the evidence is, it's there, but actually we haven't felt the need to do it. So it's not because we can't, it's just that we've had and do have good results from the ambu bags and such like. And obviously the ease of an ambu bag is much more than popping a vest on and stuff. So we've just tended to do with what we have the most experience in and find effective, to be honest, rather than it being down to a geography.
Great, thank you. That's really helpful. So yeah, Jodie, I'd love to hear about your experience with Fraser and sort of that relationship you have with the team around you, and maybe some of the equipment that you use at home and the sort of care that Fraser receives.
Yeah, thanks, Rob. So Fraser is 7 years old and he's been established on overnight bi-level positive airway pressure, or what I would call BiPAP, non-invasive ventilation, for 9 months now. So before he was established on BiPAP, he was really concerning me. So he was a very poorly little boy, and he always has struggled physically, particularly with fatigue. But it just seemed to me that he was declining every single day. The time that he was spending out of his bed was just not as much as he was spending in it. He was reluctant to do anything that he loved to do, including playing his Xbox. He was substituting all of his meals with milk. He was too tired to eat. So he lost a significant amount of weight. And his short-term or working memory became non-existent. So he just couldn't remember anything. It impacted him academically. And he was also displaying really erratic behaviours and emotions that he hadn't displayed before. He never ever has slept through the night, and I raised my concerns from the get-go. You know, kids are not built to sleep, and I was told this over and over again. We were referred eventually to Sleep Scotland, who done a study on his sleep, and they proposed a kind of routine. But I was a bit reluctant to follow their recommendations because deep down I knew it wasn't behavioural or because of a lack of routine. So then we were offered medication to assist with his sleep. The bottle is still in my fridge to this day unopened because just mother instinct, I was petrified. You know, I knew the way he was sleeping just wasn't okay. You know, it wasn't an inability to just shut down. There was so much more to it. It was like he was scared to go to sleep. And I was worried that if I medicated him that something horrible would happen. We had countless sleep studies at home, and the results were absolutely perfect every single time, and nothing caused concern there despite how he appeared when he was sleeping. So he was limp, lifeless, his eyes were black, he would choke in his sleep. You know, sometimes I felt like he was going to swallow his tongue, or it was like when he fell asleep, there was a button inside him that got pushed and his whole body just shut down. He was also screaming. I'll never know if that was out of fear or pain, but while he was asleep and sound asleep, he was crying. So it was actually Christmas Day last year. Fraser woke up and was so uninterested, couldn't open his presents. He was far too tired. He just wanted to go back to his bed. And after a busy Christmas Day, he went to bed, and within an hour, he was displaying all these symptoms. And I just had one of the erratic mum moments where I started filming him and sending videos to his nurse and his doctor. So, so he was taken into hospital for assessment, and as he fell asleep, his carbon dioxide levels did start to climb. I can remember lying in a little bed at the end of his bed, and the nurse stood outside his room and phoned somebody, I think it was maybe a doctor, because his CO2 levels had reached 9.4, and they stayed at that. They weren't going up, they weren't going down, they just stayed at 9.4 consistently. So I was lying in this bed on Google. What does this mean? Absolutely terrifying myself. And the respiratory doctor was with us before the sun even came up, I think, and explained that the symptoms that he was displaying, along with evidence of the high carbon dioxide levels, were a result of hypoventilation. So my understanding, I may be wrong, Dr. Davidson, is that Fraser's breathing is too shallow and too slow as a direct result of his generalised weakness to meet the needs of his body. So as a result, he's not effectively gas exchanging, meaning the carbon dioxide builds up and leaves too little oxygen in his blood, and it leaves him feeling nothing less than awful. And that's when I was advised that Fraser would be established on ventilation. And this felt very similar to being hit by the diagnosis train all over again. I was absolutely terrified, and I don't think I heard anything after that, no explanation, nothing. I just heard that he needs ventilation, and I was so scared. So 9 months later, Fraser is well and truly established on his ventilator, and his life has never been better. It improved every single aspect of his life within weeks, and all my fears were totally eradicated. It doesn't limit his life in any way. That was one thing that I was really worried about. Can we go on holiday? Can we have sleepovers? You know, can we go on long car journeys? And yeah, we can. We do everything more than what we've ever done. This last 9 months alone, that machine has been to the very top of Scotland and also down to London, you know, stuff that we could never have done without it. He's happier and he's brighter than he ever has been, and he's coping with full school days and weeks. His diet's improved, he's regained a lot of the weight that he had lost previously, and he's got his get up and go back. He's just a happy, alert, busy boy, something that I could have only dreamed of. But most importantly, his resilience and bravery was amazing. I personally couldn't imagine adapting to something like that at such a young age as well. But like everything, he took it in his stride, and within days of being established, he was thanking his doctors for his machine because it made him feel lovely. In his own words, he felt lovely. And Fraser loves nothing more than going to his bed at night and putting his mask on. I don't need to ask him. He doesn't need a reminder. He's quite happy. I've caught him a couple of times after a busy day at school, lying in his bed with his mask on, and he'll say, I'm just chilling. You know, he feels the benefits instantly. And we were prepared for not seeing very many benefits suddenly, but we were very lucky. And yeah, so it's really been the most welcome piece of equipment that we have ever had. For being something that I was initially terrified, it's something that we truly cherish, and we're very lucky to have.
Jodie, thank you so much for sharing your story, that Fraser's story. That was really, really helpful, and really sort of clear explanation from the patient perspective. Really struck by sort of your comments there, sort of chime back to what Dr. Davison about your role being around not only the data but the way patients are feeling and their experience of it. And I think that's a really great illustration of how that has to all come together. Before I turn to Mahesh, actually, be interested to hear from Alison and Dr. Davison about whether that strikes me that I suspect quite a common fear about ventilation coming down the road, and kind of how patients adjust to that. Is that a really common way that you sort of support people in terms of just coming to terms with the fact they need ventilation and how to adjust to it?
Yeah, so I don't think you can ever underestimate how devastating it must be to hear that you need a machine to help you get a full breath, if you like, and you know, it potentially marks another stage of a condition. People will have a fear if you go onto one of these that you're going to become dependent on it, or does it make your muscles weaker? And there's various things, and Jodie touched on it. And I have to say, in terms of being a medical type doctor, I can give people pills, I can give them inhalers, I can do lots of things. There's very few treatments I can give that make people feel better to the level of a breathing support machine. However, if I said to Jodie, I want you to go and wear an NIV machine tonight, it would get in the way, it would feel noisy, it would feel obstructive and obtrusive, and she'd hand it back to me in the morning and say, that's awful. But if you need it, it completely can be transformational. And for a bit of medical equipment, I will have people describe it as their best friend. You know, and I think Fraser's describing that in his own way. And I think in terms of the weight loss, depending on the type of condition that folks have, you can lose weight because you're breathing shallow, but you're breathing fast for some folks. So it's as if you might be sitting, not moving very much at all, but you're running, if that makes sense, because you're just burning calories the whole time. And other things, again, I guess what you were describing there about weight loss and not interested in food. So your carbon dioxide, for some folks who get hangovers, it's a bit like having a hangover all the time on occasion, so you don't feel like it. But also, if you go through the act of eating, you hold your breath while you're chewing. So if you're breathless in the background and then you're being asked to eat, you're just going to stop eating because you're holding your breath, and then you get more breathless and more tired. So I think it rings true, and so much of it is about the timing of when to go onto one of these, and it doesn't speed things up, it doesn't make things worse, it just will make you feel better in the vast majority of people. Don't know if you have anything to add to that, Alison.
No, totally agree, and I think it is when you're putting somebody onto ventilation, you need to remember is we're not forcing you to use it for 8 hours every night. We tend to take your time, get used to it, try it during the day. It's just what Jodie said, and once you get on it, it's the best thing. Changes everything. I'm struck with the parallel between some of the stories we hear from people about how they felt about moving into a wheelchair and losing ambulation. And actually they were very worried about that would speed up the progression or be a real sign that it progressed. But actually, in retrospect, that was a moment that gave them real independence. So it's fascinating to hear the parallel there. Mahesh, I'd love to hear from you now, if that's okay, in terms of your experience of the respiratory support and the relationship you've built with the team around you. I think Dr. Davison said something that really struck me, which was a gradual evolution of symptoms. And I'm wondering if that was something you experienced with your condition.
Yeah, so I'm 38 years old and I have DMD. I first started using respiratory aids, i.e. IV and cough assist, at the age of 26 in 2009. This was after a near fatal respiratory crisis, which resulted in me having to have a tracheostomy. This was due to not being transitioned to adult services appropriately. I now have a well-managed respiratory care through the Lane Fox unit in London. This is greatly supported by managing infections in the early stages, the daily use of a cough assist machine to clear any lingering secretions. For me personally, and I'm sure a lot of people will agree, that a cough assist machine is literally a lifesaver. Now a bit about masks. It's important to get a suitable ventilator mask that fits well, is comfortable, and has minimal leakage. So a mask that fits me comfortably won't necessarily be suitable for others, as we all have a different size and shape faces. At first, masks are difficult to get used to, but you just have to try different ones and figure out which one is best for you. I personally use a nasal pillows mask because it's the one I find the most comfortable. I've tried using bigger masks, like the full face ones, but haven't got on with them. That being said, I've met others who prefer the larger ones. It's all about personal choice, really. Yeah.
Thank you, Mash. That's fantastic. And Dr. Davidson, and I guess Alison as well, in terms of the service, you mentioned you have lots of equipment. So is that a real theme? It's a bit of trial and error in terms of what works best for individuals and their sort of comfort.
Yeah, definitely. There's loads of masks on the market. I think there's two. So you've got a full face mask or a nasal mask. You've really only got two masks, but there's a lot of them. And everybody's like obviously online now and see so many. The only thing I would say is don't be tempted to go and buy your own. Always run it past your professional person, because some of them have got vents and different things on them. So just make sure they're compatible with the machine that you're on. But definitely, it's just it is trial and error. And some people, with the amount of masks and people that we put on to ventilation, it's amazing that there's a minute amount that don't find something, do you know, like, so you would think that you'll maybe get a wee bit of hassle with one person, but it's in the grand scheme of things, there's like 2 patients in the year that might take a wee bit longer to get fitted with a mask than 100. Do you know, it's amazing.
We've had a really interesting question that's come in around the sort of CPAP for travel. So someone who talks around the fact that actually having a CPAP machine has allowed them to visit, travel longer distances. Is that a common thing? And I guess if I could come to Dr. Davidson first, but then also Jodie, I was very interested in your experience of being able to travel with Fraser's equipment.
Yeah, so we and obviously I don't really want to go into patient identifiable information, but we have folks that have been to very, very far-flung parts of the world, and they'll take their ventilators with them. So I think it's really important, obviously, around the battery health, around making sure you've got the right power adapters, making sure you've got enough backup, making sure you've got enough backup for your backup, if you like, and having that planning in advance. But certainly being on breathing support does not stop you from traveling, and it gets through. There's some important practicalities, like it doesn't interfere with your hand luggage amount. You take your ventilator through with you and stuff. So, people get really anxious about those practicalities, Rob, but certainly we have folks with neuromuscular conditions that have been, I think, around a large number of countries around the world. Yeah.
So Jodie, has that become part of your? So I have a 7 and a 5-year-old as well. So I know getting out of the house for any more than 12 hours ago is a stretch anyway. So has the respiratory equipment become just part of the routine of packing it now and making, and as Dr. Davis said, making sure you've got the sort of backups you need as well?
Yeah, and as well, I'm sure you'll understand that when you put a 7-year-old and a 5-year-old in a car, they fall asleep straight away. So Fraser would go to sleep in the car being absolutely fine, in a relatively good mood. And when we woke him up, when we got to wherever we were going, he was just not up for it. You know, even 20 minutes sleep has such a massive impact on the rest of his day. The way he slept in the car, so he was literally gasping for breath, which is something that I wasn't aware of at the time. So he has always slept with his neck nearly stuck to the back of his back. You know, he really flexes his neck when he's sleeping. And that was something that he'd done in the car. So especially driving myself, it was difficult to concentrate on driving and concentrate on Fraser's breathing or sleeping. So yeah, it kind of put us off doing stuff. But now Fraser's BiPAP has a 4-hour backup battery on it. And I do know from speaking to the nurses in the hospital that there's families that get a few additional backup batteries, or bigger ones, I believe, that can still go camping. And, you know, it really has added to his life rather than taking anything away from it. I always change the filters. If we stay in a hotel for a night, I will always put a new filter on it for when we come home. That's my personal preference, but better safe than sorry, I believe. Yeah, so we go everywhere with it.
And Mahesh, same question to you, I guess. Has sort of when you're going out and about, has it become a kind of just a part of the routine, like around so making sure you've got the respiratory stuff around you, or does that take special planning?
It is kind of like a routine. I've got ways of like carrying it all with me. Like I've got a suitcase just to stick everything in there, and then at least it's like stick it in the van. Just to have it there gives you more confidence, really.
Brilliant. We've got a very pertinent question in advance, given the temperature changes outside. But is there some general sort of best practice and advice that you'd always give in terms of the respiratory issues during the winter season? I'll go sort of first to Dr. Davidson, and then come to sort of Jodie and Mahesh in terms of, sort of personal tips as well would be really helpful. Alison may want to come in as well as in terms of the advice you would give to sort of patients on a regular basis about winter changes.
I'll probably start and stop with vaccination. Get your JAGs. That's really important, obviously. And then I think a lot of it is planning, Rob. A lot of it is planning. A lot of it is make sure you've got your stuff, make sure it's all charged, be warm, and keep warm, because a lot of folks can feel the cold quite a lot. Particularly, we find a lot in folks' lower limbs as well, their legs and stuff. So a lot of it is planning, but a lot of it is be sensible. Around people that have respiratory tract infections, the sort of viral infections, and obviously that's a whole new understanding for folks in the last 18-20 months. But certainly vaccinations are really, really important, I would say.
And Alison, do you see a kind of uptick in calls and queries to you from patients as the sort of weather gets colder in the winter, or do people sort of used to now planning ahead?
I think they're probably used to now planning ahead, and I think we've always kind of said to them, if your carers are coming in and out and they've got colds, they tend to be quite sensible. Most people will not let them in, and they'll do all these things. It's just, yeah.
Thank you. And Mahesh, how do you sort of change your behaviour or kind of your preparation for going out in the colder months?
Very much, yeah. It's quite difficult in the winter, definitely, because obviously you're prone to getting these colds and things. So yeah, and you can end up with a chest infection, and it can deteriorate even further into pneumonia and end up in the hospital. I normally just keep a course of antibiotics at home. So if I develop like 2 or more symptoms, like temperature, etc., just keep those at home just to get on top of things early, really.
I think it was a really interesting sort of hearing people as we built our guidance at MDUK when sort of COVID first appeared, and we were talking to our community about the impact of lockdowns and things like that. A strong theme that came through was actually, look, I live in lockdown every winter because I take precautions around exactly that, around getting chest infections and pneumonia. So it was fascinating sort of to hear that. And Jodie, does Fraser sort of need extra support in the winter? Does the sort of temperature affect his respiratory needs?
Not really. We've actually been really lucky with Fraser. So he's actually had 2 common colds in his full life. However, both times he was hospitalised. So it really does affect him quite badly. His body can't cope with illness at all. But I do advocate the flu vaccination. So he actually gets his tomorrow. The only thing is that the community nursing teams that go into school and do the school take a look at Fraser's form and say, I'm not touching that, do you know? So we always need clinical confirmation that it's okay for him to have it, which it always has been, and he's always been absolutely fine with it. So yeah, he definitely gets that every year.
Brilliant. Thank you so much. Well, I think that draws us to an end actually of the time available. This has been a fantastic session. So huge thanks to Dr. Davidson, to Jodie, to Mahesh and Alison. Thank you.